All right, Nothing Stronger Show, episode 5, I think. I actually have no idea. But today we are talking about shoulder impingement or quote unquote shoulder impingement. And we're going to allow Jen to dive into what it is, what's going on, and why your shoulder could be bothering you may not be the reason that you think it is. So, heavy questions. First, Jen, what is shoulder impingement, or what do people mean when they say they have shoulder impingement? And what's your take on shoulder impingement?
Yeah, so my take on shoulder impingement, I'll start here, is that it's this really non-descriptive term that doesn't help the consumer or the patient to understand what is going on, right? It's kind of this blanket term that could really mean 3, 4, 5 different pathologies. And it basically just means like an encroachment on that space, right? That impingement. There's supposed to be space that's living there within the shoulder, and it's not. So it's starting to that shortening or that narrowing of space is starting to push on structures. So we typically see this, and if I turn myself, right, we typically see this when the shoulder kind of rounds forward, right, because we sit here and we text and we type and we watch TV and we drive and we have, big push, not a ton of pull in our programming or whatever it is. And so that offsets and kind of drives our shoulder to the front. And so what ends up happening is on the top of the shoulder joint, right, there's a few different structures that live there. And if we create a smaller space on what is already a really small space for all of that to live normally, we can just start to encroach upon that space. So typically, the 3 structures, sometimes more depending on how nitty gritty you want to get into this, right? But the 3 kind of primary structures that might be injured is your supraspinatus, which is one of your rotator cuff muscles that allows you to come into this like scaption, kind of coming up at like a 45-degree angle. Your bursa, which is just a fluid-filled sac in between some bony structures in there. And that really acts as a shock absorber and a force distributor, or the long head of your biceps tendon as it starts to come up from your upper arm into that shoulder joint. So any one of those structures, sometimes more again, can get impinged, right? But I think as a consumer, we need to do a better job when we hear that term of saying, well, right, that doesn't give you a diagnosis, right? Shoulder impingement, just because it's this blanket term, doesn't tell you what structure is being impinged. And more importantly, why? Because the why is really where you're going to get the results from rehab or from programming, in the gym and that type of stuff.
So the biggest takeaway from that is like shoulder impingement like isn't a thing. It's not like a one thing. Like it's like you can't walk away and be like, I got shoulder impingement, because that gives us no answers as to what the next step is. Is that correct?
It's just not a clinical diagnosis, right? It doesn't tell you anything that's going on. More importantly, how to fix it, right? If you just say, it's basically like saying I have shoulder pain, I have knee pain. Well, awesome, but what are you going to do with that information?
I guess a question from like I guess as a patient, like what would I do to help figure out like what kind of impingement or what is causing this? Like what's the best step as a patient in order to figure that out?
Yeah, so a comprehensive evaluation, both from a subjective assessment, what the client or the patient is telling you, a palpatory exam, as well as some functional and special tests that the clinician can do, can really tell you specifically what structure. Obviously, advanced imaging is, but I would say, I think it's when a lot of people have, knee, shoulder, back pain, I think that the quickest thing that people always want is an MRI, right? Like, let me get an MRI so I know exactly what's going on. And oftentimes that's not necessary, especially if an MRI should really be used if you are trying to evaluate and find, like, do I need to do surgery on this, right? Or does some sort of advanced procedure, invasive procedure, need to tell me exactly what's going on so that I'm able to participate in this? If it's just based off of, so I know, it's not really, sometimes you find out things that you don't want to know, right? And what shows up on an MRI isn't always what your pain source is. If you take a shoulder MRI of 10 people, I guarantee you all 10 have something going on in their shoulder joints, but that doesn't necessarily mean that that's where your pain is, right? So really the functional assessment is really where you're going to get the most bang for your buck, in the sense of what's going on, what is my pain pattern telling me, and how do I fix that, right? So as the patient, when we go through, there's very distinct spatial differences of, is it my biceps tendon versus my supraspinatus, that rotator cuff tendon, versus is it my bursa? And so a lot of times the palpation exam will tell that, and then also some of those special tests, but also going through and identifying, okay, why is the shoulder potentially in this forwardly rotated position, right? Is it that pec minor? Is it my lats, kind of wrapping around that rib cage? Are my rhomboids and the muscles in the mid part of my back really in this locked long position instead of, drawing that shoulder blade back? Oftentimes, and this is probably getting a little too far ahead, right? But oftentimes it's because our shoulder blades live on the lateral aspect of our rib cage instead of kind of coming back and down. And our shoulder blade is the foundation and kind of that set for the shoulder joint. So if the shoulder blade is not in the right position, there's no way that the shoulder joint or the structures coming through the shoulder can live in the optimal position as well. And then once you get into exercises, and again, this might be going a little bit ahead, but if your shoulder muscles are not in their resting starting position, you're not going to get optimal contraction of them, whether they are locked short or locked long, because they're just not in that position to optimally recruit and ask that to produce force. So oftentimes if you're just doing exercises without managing some of that pain symptoms, it's going to just kind of perpetuate the issue as well.
So going off that, like a lot of times there's people and like they work out at the house, they work out at the health club, they don't come to a facility like Lift and Stronger, but they're doing very like traditional PT exercise, like pendulum swings or like the 990, like swinging the arm, the road cuff. Can you like train yourself with basic exercises out of shoulder impingement without the knowledge of the global structure of the shoulder? Or is it just like what's going to help that person most that's doing it on their own is the time that they're maybe not doing that one thing that's causing that pain? Like, does that make sense when I say that? Okay.
Say it again.
Traditional physical therapy exercise, right? If someone's in a health club and they're doing pendulum swings and they're doing their like external, internal rotations with like a band or like sometimes a 5 pound plate, are they gonna train out of shoulder impingement? Or are they just gonna feed into more symptoms to feel more symptomatic?
Yeah, no, because you're not, again, in order to get out of that position that makes impingement vulnerable, you can do internal external rotation all you want from here, but you're not changing this posterior direction of the shoulder to be able to kind of slide to the back and give that space and freedom here. So really when you're trying to effectively manage with exercises alone, you really need to train where the shoulder blade sits. So you come down and back through there, and you need to open up through this front area, because what we oftentimes see is pulling down like through scalenes, SCM, but also like right underneath the clavicle. We tend to just draw forward through that clavicular pectoral fascia right through here. So we really need to, one, help open up here, two, get those shoulder blades back, and we need to focus on the cervical spine as well. If you're just doing, I think the tricky part about this is great for very, very foundational recruitment of the rotator cuff muscles, two of them, really. But we don't live in this world, right? And so oftentimes that's why they're given, because it's just very minimal activation, but it's not functional. And it doesn't translate to, I'm going to reach for something in the cabinet or driving or trying to put on my purse or a jacket or things where I can't live below 90 degrees here. I have to be able to come into some abduction and flexion of the shoulder. And so if we're missing that part of our rehab or the exercises, very rarely do you get fully out of that shoulder pain.
And just curious, as far as like, activities of daily living and how you operate throughout your day, is there, everybody's always saying like you should be sitting in a certain way, you should be sitting upright, you should adjust it. Does that make a difference with like how your shoulder feels or how your posture is, or is that just kind of like a band-aid that you're slapping over it?
No, posture is a huge part of this. The really tricky part is our awareness of our posture, right? Without it, because we are in our posture, our normal everyday posture, is embedded into our nervous system, into our fascial system, into our muscular system, our joint capsules. And so to become aware of that, right? I can say, okay, I need to be aware of my posture, and I come back and I sit up tall. Well, 3 seconds later, when something else draws my attention, I come back in because it's woven into who I am. So that doesn't mean that you can't fix your posture, because that's going to be a huge part of it. It's really getting the rib cage up and back to be able to allow for that thoracic spine to live in a little bit of extension and not that lordosis, right? And then I can work on rotation of the thoracic spine. I can work on getting my neck out of the front aspect of my rib cage and chest and being able to get back into the normal kind of curvature of my spine. And then from there, now my shoulder is in a better starting position to be able to get into motion. But if I don't fix my rib cage, my thoracic spine, my cervical spine, I can't really truly fix the shoulder joint.
So when your patients come in to see you and they have like this blanket term shoulder impingement, you know it's their bicep tendon, their bursa. Are you treating it that session, or are you focusing on I got to go after the rib cage first, or I got to look at the pelvis first? Like, are you like? Because I'm sure patients want to feel like they're getting the benefit of what they came in for, whereas you know as a clinician of like this isn't going to do much here. I have to focus on these aspects first. Like, how do you go about the evaluation process or the rather the treatment process of like what you found in the evaluation process and how to treat that person while making sure that they are there for the right expectations that they have.
Yeah, and so that's really where, after we go through our kind of comprehensive evaluation of the patient, and then we go through what can be therapeutically helpful from an intervention strategy, manual therapy, exercises, modalities, whatever it is, and we align those with clinician goals as well as the patient goals. What I often tell people is, this is your hour, right? Like, I'll use my expertise. If you give it up to me, I'll tell you the path I think we should go. But at the end of the day, this is your hour. And so we can use this how you want to, and then we'll see where we get. And just kind of giving them the freedom and the autonomy of that, I think, is helpful for that patient buy-in. It's tricky because when you're fixing things that have been perpetuating for a long period of time, you have to set these realistic expectations of, this isn't something that gets better in 6 sessions typically, right? This isn't something that may get better if you, right? And somebody might come to me and be like, Jen, I've been seeing you for 6 weeks, right? You may see me 1 hour over, so 6 hours total. All of the other hours that you've spent over those 6 weeks reversing everything that we've tried to accomplish in here, right? And so when you're trying to figure out how best to manage people that have been in pain and the expectations that they have, oftentimes you have to treat the pain, right? So we may go through modalities or manual therapy techniques that are directly targeting the biceps tendon or the bursa or the supraspinatus, or whatever structure we think that we really need to hit on, as well as some of those larger kind of areas around that might be holding that in. So I might go after the pec minor, I might go after the lats or the upper trap. That will just take a little bit of that pressure off of that chokehold of the shoulder. But then really where you're going to get the longest lasting results is once as you start to fix the thoracic spine, the rib cage, the cervical spine. And so I often will say, listen, let's spend a few sessions on that immediate surrounding area. If in your off time, if you want to go through and we give people, a rehab program to do with some videos, that will really help them to give some time necessary towards the thoracic spine, towards the cervical spine. And those are all really low risk exercises where people aren't really hurting themselves, or if they do it a little bit wrong, it's not going to be the end of the world. And then from there, we can really fold that into our treatment plan here, where now it can become a little bit more dynamic, but you have to help to start to alleviate that pain before you give people exercises that are really going to feed that whole system. Because if they're just focused on the pain, you can't there's like this disconnect of the brain of like optimal recruitment for more dynamic movement patterns when it's still trying to process the pain that's happening in the shoulder joint.
So it sounds like it's almost like that initial like treating that the site of the injury is almost like a mental game of like kind of take the focus off that area. That way you can realign different structures without like, guarding that certain area of say the shoulder or whatnot. Is that right?
Yeah, I mean, so one, it's mental, but two, it's definitely, your nervous system too, right? Like I say this line all the time to a ton of my patients, and then I kind of break it down. Altered afferent input is going to lead to altered efferent output, right? And so if what's going into the brain says, ow, this hurts, it's hot, it's uncomfortable, it's tight, right? Like what does tight mean? Tight can be locked short or locked long. It's not indicative of something actually being in this adaptively shortened position, right? Whatever sort of altered information is going into the brain says, how can I protect? How can I do this? Taking the path of least resistance. And 99.9% of the time, that is imbalance of muscles, joint capsules, space, ligaments, tendons, fascia. Things are not all working in harmony because it's trying to say, okay, this hurts. I'm going to guard and protect here, but then I need to over recruit here. I need to under recruit here. And so it just becomes this turf war battle of that myofascial system.
So, I mean, we're pretty aware of your patient education process and your evaluation process, and as we go down this shoulder impingement road, we're going to talk about it, we're going to eval it, treat it, and then train it. So the next step of this is the eval process. What does your eval process look like when someone comes in with this? Like your patient education side of it. Like you're not getting someone on the table in the first 10 minutes. So when someone hears everything that you're telling them from the patient education side of it, like what are they like, how surprised are they, how are they acting, are they like, oh my god, this makes so much sense? Because I'm sure you need that buy-in from a patient side of it, that it needs to connect with them. If you want them to get better, if they want to get better, there needs to be this mutual buy-in of like, do you understand how this is happening? Now let's go and fix it. So what's your first session look like this comprehensive evaluation? Like how much education you give them, what are you showing them, and how do you get that buy-in from a patient?
Yeah, so after we go through and sometimes it's even like woven into the exam because I want people to feel things as I'm showing them things too, because I think it is more translatable too. So sometimes it's like just woven into the exam. Sometimes it's after the exam and, I'm taking notes and stuff like that, or I'm saying, hey, do you feel this? Remember this. Or do you see this? Remember this, right? Because we're going to come back to that. And oftentimes I also take pictures for people because when you see a system of standing of, what I think I look like standing versus what I look like standing up against a wall, and somebody taking a picture are probably two very different things. They're the good or the bad. And so people are often amazed at what they see and sometimes people are like, that looks normal to me. And then I mention one thing and they're like, oh my goodness, how was I living like this? Right. And so when you show somebody the whole system and then you bring them back to the patient education side. So oftentimes I have some, kind of pictures that I really like to show online, I think we go through a lot of the skeleton, looking at it from there, the bony pathology, the joint pathology that might be going on, and then tying that into a functional muscular system, right? Not individual muscles. It's just this muscle. It's just this muscle, right? Like, how does that feed through that whole? How is that giving information to that joint of where to live? And that's typically where I think I get a lot of people to be like, oh my goodness, I understand this, right? Because oftentimes when you go to the doctor's office, you might have 5, 6, 7 minutes tops with a PA or with a physician, and they might say, hey, yeah, look at this little, and circle one thing on your x-ray. And you're like, what am I looking at, right? Like, I don't even know what that means. You walk out to the car and you're like, I can't even tell you one thing that they just told me, right? And so it makes it really hard to understand and to feel empowered about what your injury is and how best to manage it. And that's why people take these shotgun approaches, because they see videos on Instagram or TikTok or their best friend was doing it at the club or something like that. And they're like, oh yeah, this will work for me, right? And it becomes this cyclical, shotgun approach of trying to manage these rather complex and individualized injuries. Not to say that a program can't be translatable through people and they get benefits out of it. If if what you have going on and something that's been neurologically ingrained in your body for 20 years is probably not the same thing as Joe 2 bench presses over or something like that. So we show them that. And then oftentimes, I'll get out some books and kind of show people from, like a whole system wise of what we're doing. And again, I think that illustrating and showing and then bringing it back to what I'm seeing for them is really helpful for them. And that's always kind of the best feedback that I can get as a clinician is like, I get it now and I understand it now. And typically people have more buy-in when they understand how messed up they are as well.
I have to say, like just from a physical therapy standpoint, like you never get a picture if your shoulder, you walk in, your shoulder is hurting, you never get a picture taken of you of how you're standing. And I think that's something that's pretty unique. It's that, like, the closer you look at the shoulder, if you're just looking at your shoulder, it looks great, it looks fine, like doesn't seem like there's anything wrong, but how it relates to the rest of the body and how it's positioned, relative to the rest of the joints can be extremely eye opening, because it's not something you see in the mirror on yourself. So I think that's pretty interesting, that
I
part.
think one really unique concept that I probably didn't learn until a little bit later in my clinical realm of how to describe and evaluate, right? Is I think we always think our bones are stacked upon each other like these building blocks, right? And so our our feet transmit forces up, our head transmits forces down, right? And so when you get these like compressive injuries or traction based injuries, whatever it may be, everybody just always assumes it's the joint is just the joint, or the space of the bones is just the space of the bones. But there's this really unique concept of the bones actually float throughout the tension being placed, or the slack or the compression of all of the dynamic soft tissue. So the fascia, the tendons, the joint capsules, the ligaments, they float within these structures. And so you can adapt the position of the joint space or the bones by adapting the information that's getting loaded into these. And so instead of just giving up and saying, I have this injury, it can be translatable, but not from one muscle doing everything, right? Like if you think you're just fixing one muscle or one side of that space, you're missing the whole boat on this whole thing.
That's really interesting. I think, like, in school you learn about, like, the human body, and you think it's just like this skeleton getting moved around by a bunch of, like, joints and, or a bunch of muscles and, tendons and pulleys, when it's like, I don't know, I like that point, almost like the bones are floating around in that,
It's
like,
really
those
cool.
layers of
It's really
tension.
cool for me
I
because
never thought about
I
that.
obviously like it. It's cool for me because I live with Jen. I see her watching YouTube videos of certain clinicians and books and projects and getting ready for presentations. So it's cool to hear her talk about it. But it also makes me worried that Jacob and I are going to get kicked off this podcast if we don't get smarter real quick. So I'm a little intimidated, but I'm
Yeah,
also like really like cool that I get to like watch you talk about like what it is you study day in and day out. So
yeah, absolutely.
Jen, any closing remarks on shoulder impingement, or you feel like you hit 10 nails on the head?
I think my biggest takeaway from it is just if somebody isn't telling you the why of the why or what's actually feeding into it, don't settle for this blanket term. Oh, you have tendonitis. Oh, you have bursitis. Oh, you have, all of these things. Well, what does that mean and why? And if somebody's saying, oh, it's this one muscle, like if you have patellar tendonitis or biceps tendonitis, and they're like, oh, yeah, you just need to strengthen this one muscle, ask for more because it's not, right? And so that's my biggest takeaway is challenge whoever is giving you these to give you more, because that's when you're gonna hopefully, if they're able to give you more, that's where you're gonna be able to figure out what's going on and why, and how that step and that plan to actually get better.
I like it. Makes sense to me. So week two will go an evaluation of myself for Jacob, and however you want to structure that based on a case study, based on, if that, then that. So you can decide that. But I appreciate it. Thank you, Jen.
Thanks.
Awesome. Thank you.